Good morning, and thank you, Chairman Buchanan, Ranking Member Doggett, and distinguished members of the Health Subcommittee. I'm honored to speak with you today regarding the role that remote patient monitoring plays in empowering patients by collecting, analyzing, and displaying digital health data to patients and to their care teams. Whether you prefer the adage, measure twice and cut once, you can't change what you don't measure, or what gets measured gets done, it is clear, to make America healthy again, we must start by taking the measure of the patient. My name is Andrew Zengilowski. I am a co-founder and the Chief Executive Officer of CoachCare, and I'm a founding member of the Remote Monitoring Leadership Council. For more than 10 years, CoachCare has offered remote patient monitoring technology to independently owned physician practices. We are an extension of the clinical staff, and we focus on achieving improved clinical outcomes, practice efficiency, patient satisfaction, and a lower total cost of care. The Remote Monitoring Leadership Council is a collaborative of 7 innovative companies operating across all 50 states and collectively offering the majority of remote patient monitoring services being delivered to Americans today. Members of the committee, thank you for taking the time to discuss the importance of digital tools as part of our healthcare future. Each of you have constituents benefiting from RPM as we sit here today, and each of you have independent physicians living or working in your districts that rely on remote patient monitoring to treat their patients and to retain their independence. While delivering high-quality RPM is complex, at its core, RPM is a simple and common-sense service. For decades, physicians have instructed patients with hypertension to buy a blood pressure cuff, take their measurements at home, and keep a log. They have been instructed to bring that log back to their next appointment, usually 6 or 12 months in the future. RPM technology represents a simplification and enhancement of this common practice. We ship to the patient connected, FDA-cleared medical-grade devices to track vitals. We use FDA-cleared devices to ensure that the data we receive is valid for use making life or death clinical decisions. We also pull data from consumer-grade wearables, such as those that Secretary Kennedy discussed during yesterday's House Energy and Commerce Committee hearing, to provide context. While we can't use consumer products to make medical decisions, we can benefit from the additional context that they provide. The data captured by these devices is transmitted to our software, analyzed, and presented both to the patient and to their care team. This allows near real-time interventions, often avoiding the emergency room and preventing costly hospitalizations. Hypertension is called the silent killer for a reason. The first symptom a hypertensive patient usually experiences is a heart attack. We are going to talk a lot today about the dollars and cents of digital health, and I thought it important to take a moment to acknowledge that we are also talking about life and death. These catastrophic and costly outcomes are avoidable by monitoring the patient and using the data we collect to titrate medications and adjust lifestyle factors in near real time. We are going to talk a lot about primary prevention today, but we should not discount the importance of tertiary prevention. We cannot ignore the more than half of the adult population in the United States who already have at least one chronic condition. Members of the committee, I have good news. RPM is incredibly inexpensive. I can monitor a patient for 50 years for the cost of an ambulance ride and a few days in the hospital, which is unfortunately a near certainty if we do not manage these chronic conditions. Across a cohort of 450 patients suffering from advanced chronic heart failure that CoachCare manages, we reduced the hospitalization rate from 19.8% to 1.7%. When applied across the more than 6 million Americans diagnosed with CHF, a similar reduction in hospitalization rate would save $24 billion annually. We believe RPM is a flagship example of harnessing the power of digital health because without patients and providers having vital and valid data at their fingertips, neither can be an active participant in ensuring better outcomes, and money will be wasted. Additionally, leaders in the RPM space are moving toward models that leverage AI to fully realize the potential of the voluminous patient data captured through RPM. AI is helping to detect conditions sooner, lessen the burden of paperwork, and support clinicians in making optimal care decisions. Actions from CMS to specifically support data and technology costs are crucial to unlocking the potential of advanced data capabilities like AI alongside RPM. We urge the committee to work with the industry to modernize RPM payment to ensure continued expansion of this proven digital health tool while safeguarding program integrity. Medicare cuts unrelated to the performance of RPM have continued, ranging from 7% for treatment-related services to an astounding 33% for technology-related services. RPM providers, particularly small providers who operate on tight budgets, are reaching a breaking point. I appreciate the subcommittee's attention to this very important topic and the opportunity to testify.